Hello, I'm Dr. Laukkanen, and I'm going to talk about radiation treatment for breast cancer. And this is particularly for people whose treatment began with some form of drug treatment, usually chemotherapy, and then surgery, and that have now been referred for consideration of radiation. And if you're watching this because you're going to be seeing me shortly, I look forward to that visit. So, just to review, uh, what is called neoadjuvant treatment is where drug treatment comes first, and then surgery follows. And then the question is, when can radiation be helpful as part of the treatment package? And to answer that question, we first look at how much cancer was there at the beginning before any treatment. And we could divide it into two rough groups. One is a lot, and then the other is not as much. And so, where cancer is locally or regionally advanced, where it has, say, ulcerated the skin or is fixed to the deep chest wall, or there's very bulky involvement of lymph nodes, radiation treatment is always helpful to the whole area at risk. When there's not as much, but nevertheless, there's been proven spread to lymph nodes, and where the drug treatment was given with the desire of shrinking the cancer before surgery so that the very best surgery could be performed to get the cancer in and have as little structural and functional uh, change caused by the surgery, the use of radiation in that setting is a bit more selective. Then the second thing we look at is what was actually found when the surgery was done. Is this a situation where the cancer was all gone, or was there some left behind? And then we look also at the type of surgery. Was the whole breast removed, or was the breast preserved? And if the breast was preserved, then we always add breast radiation, and for the same reason as radiation is given for early breast cancer where there has been no upfront chemotherapy treatments. So next, what do we exactly treat with radiation? So if the breast is preserved, we treat the whole breast. If the breast has been removed and there's cancer in the lymph nodes after the chemotherapy, or if the cancer was a higher risk type, then we treat the lymph node areas too. There are a few exceptions with a better cancer and say there's no sign of it left at surgery. And here's an example of a regional radiation treatment that includes both the breast and the lymph nodes. And what one can see is that there are a number of radiation beams that are set up together that covers a fairly broad region. And radiation energy is going to be absorbed by the cells in that whole area, in the breast, the chest wall, the lymph node areas. And the reason that we're doing this treatment is that the microscopic breast cancer cells, if there are any there, and often it's simply a matter of assessing risk rather than knowing that there's any there, those cancer cells would typically be more vulnerable to radiation energy than the normal tissues, and the treatment therefore can stop them from growing. Not every breast cancer has that property, but enough of them do to make the undertaking worthwhile. So I'm going to show a few examples of treated areas when it's just the breast itself. And what one can see here is that there are radiation beams that are going across the breast from one side to the other. And to look at the volume more closely, one thing you'll see is that in the area that's just below the underarm, that's a part of the coverage. And indeed, there's normal breast tissue that extends up into that area. A last point to make is that when we look at the surface, there are areas where there are natural skin folds, especially at the lower margin of the breast and at the upper part where the breast blends into the soft tissues of the upper outer chest wall and the underarm area. And because those areas are always, the skin's always rubbing against itself, that's an area where there can be greater than average radiation skin effects. just due to that friction and the challenge of the skin repairing that friction and when radiation is underway and soon after. Next, let's look at the treatment experience. Uh, Typical schedules when both breast and regional nodes are being treated, 16 sessions that take approximately 3.5 weeks. Um, if there is a close margin or under certain conditions, it's helpful to add a little extra radiation treatment in 4 more sessions so that the overall treatment can take as much as 4 weeks. Just to review side effects, uh, we'll talk about breast effects first. Not much in the first week, little in the second, maybe some little bit of redness, swelling, tenderness. But afterwards, definitely some tenderness, fullness, a sense of warmth in the breast, and skin changes that can vary from looking more tanned to pink to red, dryness of the skin, occasional peeling of the skin, not unlike a sunburn. And again, if the breast is large, the skin fold under the breast can become significantly irritated, and the surface skin layer can come off, and that requires extra care. And it's those areas that are the risk zones. And certainly, the larger the breast, the more the dependent breast tissue, the greater tendency there is to swelling or tenderness. Happily, side effects affecting the skin settle over a few weeks. Occasionally, over the long term, there can be some persistent difference in pigment or tanning, or the skin might be a bit more fragile, or it may be possible to see subtle blood vessels below the surface, but those changes are usually pretty subtle. Some breast tenderness and fullness can linger, especially with the larger breast. It's usually quite mild, but if one looks at 6 to 12 months after the treatment is finished, between 5 and 10% of treated patients will say, well, I have enough tenderness that I would call it a bother. The breast will usually feel a little bit more firm than its counterpart, but it depends. On the issue of how treatment affects people generally, some note that they have less energy, but it depends on the person. And of course, traveling to a hospital setting for treatment every day, no matter what it is, can be tiring. So next we'll look at uncommon risks of treatment. And I'll start by saying that breast radiation is certainly among the most common and straightforward treatments. And as cancer treatments go, it would fall into the better category. But rare possibilities include treatment effects on the various tissues that are in that target area. So we saw that the beam goes through the breast or chest wall. Underlying those structures is the lung, and a small amount of lung tissue is inevitably incorporated into the treatment area and typically isn't bothered to the extent that one would notice it. But inflammation of the treated portion of the lung can occur, and that can cause a cough. It can be like a little localized area of pneumonia, and indeed it's called radiation pneumonitis. And depending on the severity, it can just kind of run its course, or it can be treated with some anti-inflammatory medications successfully. Next, the ribs that are in the chest wall in the treated area, over time they're slightly more predisposed to osteoporosis. But if a person takes a proactive approach to keeping up their bone density, the risk of delayed, late, uh, thin bone rib fracture causing symptoms, again, is happily very small. When the left side is treated, the heart is underneath, and usually a special technique is used to maximize the distance between the radiation beam and the heart. In a few people, the chest wall soft tissues can be somewhat tender, but it's not a common problem, and usually it is not much of a bother. One thing that can't be predicted is whether a person has some exceptional normal tissue sensitivity. In my own practice of many decades, I've seen one such case, but there's no way of knowing in advance whether that would be the case. And if normal tissues are more sensitive to radiation, they tend to react by becoming uh, uh, thicker, that is, subtle scar tissue forming, and with that there can be tenderness, or there can be a greater tissue fragility and susceptibility to infection. Two tiny risks: the risk of a later radiation-induced cancer, and that's been studied. It's been controversial, but one thing that one can say is that in smokers that continue to smoke, if they have breast radiation, their risk of a later lung cancer is statistically detectably increased. For other cancers, though, if there is an increase in risk, it can't be reliably picked up in big statistical analyses. And then finally, a risk of a treatment error, which is very remote given the various aspects of radiation process and the design of the treatment equipment. So we've talked about things that impact the normal tissues when the breast is treated. And if we look at the benefit side, the goal, of course, is to have the lowest risk of the cancer returning. And the amount of risk reduction depends on where we started from. But a reasonable rule of thumb is to look at the fact that risk is never reduced to zero, but it is often reducible to something that is in the 5% or so range. Now, we focused on the radiation aspects of the breast, and I just invite you to look at the companion video, Radiation Treatment of Regional Lymph Nodes for Breast Cancer, where the lymph node side of it is discussed in more detail. And thanks very much for your interest.